everyone, my name is Audrey and I'm a second-year Rheumatology Fellow from Loma Linda. Today, I wanted to share a case of IgA vasculitis presenting as duodenal perforation. We had a 67-year-old man with a history of CKD, hypertension, and testicular cancer who presented to the hospital with severe abdominal pain, arthralgias, and rash. He was rushed to the operating room by the surgeons and found to have a duodenal perforation, as well as hyperemia of the bowel, which indicated decreased blood flow. He had further workup, which included a renal biopsy, which showed IgA deposition, and his rash showed a LCV, or leukocytoclastic vasculitis. In conclusion, this patient was diagnosed with IgA vasculitis. So I wanted to share what I learned about this case. So what is IgA vasculitis? It is a small vessel vasculitis that involves immune complex deposition in the capillary beds. It is a syndrome which includes arthralgias, purpura, rash, and renal involvement. What do we know about GI involvement in IgA vasculitis? It's common. In one study, abdominal pain was the presenting symptom for 99% of patients, and also diarrhea was quite common, with about 25%. Bleeding is also seen with about 30%, and our patient had all of these. How about perforation? Well, it's quite rare. About 4% presented with acute surgical abdomen, which our patient had. What about the etiology of IgA vasculitis? Well, it has been linked to infections and drugs, and in adults, it has also been linked with malignancies, specifically solid tumors, which our patient had. He had testicular cancer. How about the histologic findings of GI biopsies? Do we see vasculitis? Well, in one study of 16 biopsies that involved adults and pediatrics, it was actually only seen in about 4 of 16 biopsies. More commonly, you'll see lamina propria hemorrhage and neutrophilic infiltrate. What is the treatment? Well, there's limited data and there are no clinical practice guidelines, unfortunately, but generally people use the same treatments that are used in other vasculitides. For our treatment, for our patient, he was treated with pulse-dose steroids as well as Cytoxan. Unfortunately, he had a very difficult hospital course with infection and end-stage renal disease, and he ultimately opted for hospice care 2 months into his hospitalization and passed away. Looking at this patient, what I learned is that for these patients, they're hard to treat because treatment often involves steroids, but steroids can also predispose patients to GI perforations and irritation to the GI lining. In addition, if you already have a perforation, you'll likely have intra-abdominal infections, and our treatments make it harder to fight those infections. Thank you.